this is Sensory Alterations, Part 2. We're continuing out of Chapter 49 in your text. This is Anna Owens, and this is for Nursing 201. We're going to start with eye diseases. First, we're going to look at cataracts. Cataracts are clouding or blurring of the lens. So if you look, there's a normal lens, there's a lens with cataract. Another picture of a cataract. This is what the vision is, just like when you have on glasses and they get dirty, what it looks like. That's what a cataract is. It's the lens of your eye that's cloudy. So our clinical manifestations are going to be that cloudy, blurry vision. Diagnostic test, you can clearly see a cataract. They may do a slit lamp exam at the ophthalmologist or the optometrist. You can also see it clearly with an ophthalmoscope. Treatments for cataracts is surgery. If a person is completely blind from cataract, their lens is completely opaque. So if we look at this picture, their lens is completely opaque. They cannot see out of it at all. They do the cataract surgery. They get this lens removed, put in a new lens. They can now have perfect vision again. Please watch the video that is available to you on Blackboard of how they do cataract surgery. It's only about 5 or 6 minutes, and that's real time. That's how long it actually takes to take a person from potentially being blind to having perfect vision again. So please watch the video on how to do cataract surgery. So the treatment is surgery. Expected outcome is for the patient to have vision oftentimes better than before they started. And pediatric patients can get cataracts. Especially, it's more common in patients with light eyes. So that's another reason it's very important for patients with light eyes to wear sunglasses when they go outside. Post-op care for a patient with cataracts. The physician will give subconjunctival antibiotics. The eye is unpatched. Some physicians will put in a patch on, but usually it's unpatched. Usually they go home with dark glasses. Make sure the patients know how to instill antibiotic steroid eye drops, because they will have to instill them usually 3 or 4 times a day in the initial post-operative period. Mild itching is normal. It is also normal to have a milky white discharge, part of the healing process. Obviously, if it's a thick yellow discharge, that is abnormal, but milky white discharge is normal. Pain is a complication. Pain could indicate a secondary glaucoma, and glaucoma is an increase in the intraocular pressure. So if that happens because of an internal bleed or an inflammatory reaction, that would be a problem. We want to teach them to reduce intraocular pressure, those same things we've already talked about, prevent infection, hand washing, make sure they know how to put in their drops, and assess for bleeding. Do you remember what the symptoms of internal bleeding are? That's right, floaters. So we just talked about this, what they need to report, and what they need to avoid, and also what we need to teach. So what do we think the answer to this question is? Appropriate post-operative outcomes. Pain, we said no, pain was a complication. Change in visual acuity, could be. Redness, that sort of throws me off because usually patients' eyes aren't red. Yellow drainage, definitely not yellow. Mild itching and bloodshot appearance, a pink eye with mild itching is normal. So the answer is D. Retinal detachment. The separation of the retina from the choroid and its blood flow, resulting in a loss of retinal nourishment and vision impairment. You can see where the tear is right there. Okay. A common cause of retinal hole tear or detachment can be a sneeze. Sometimes people sneeze. Other causes can be car accidents or other types of trauma. They will have the floaters in their field of vision. That's a sign of internal bleeding. The problem is that they can have an inflammatory response that will bind the retina and the choroid so that it it binds in a different spot and it's not getting adequate blood flow. And also remember, for you to be able to see, where does your the picture have to land? It has to land on your retina. So if your retina isn't in the back of your eye where it's supposed to be, your picture isn't going to land there, it's not going to go to your optic nerve, and you're not going to be able to see. So your retina has to be in the proper space for you to be able to have normal vision. So we want to make sure we provide information to our patients about restricting head movements. We don't want them to move their head. We also don't want to move their eye. A lot of times they will be ordered to have an eye patch placed. So please review in your text how to apply an eye patch. That is on page 1055, chart 49-4. So if we look here, here is the detached retina. There's the normal retina. You can see right here where it's come loose. Here's another, there's a retinal tear, retinal detachment. So what do you do for it? They either can do what's called a scleral buckling procedure, which is where they literally wrap a buckle around the eye to pull it together so that the retina can attach where it's supposed to be. Another possibility is a pneumatic retinopexy, which is where they inject gas. They use a needle, inject gas into the eye, so that way if the retina is falling down here, that gas will press against it so that it will stay where it needs to. The problem with this is that the head down position keeps the bubble against the detached part of the retina. So as long as that air bubble's in there, the patient needs to leave their head down. We're talking about days, 16 to 20 hours or longer. So they need to leave their head down and the affected eye up. Other treatments can be cryotherapy, laser therapy, and sometimes they'll do laser and the bubble together to try to get the retina to lay back where it needs to. Post-op care, eye patch and shield. And you want to tell the patients to eye rest. What does eye rest mean? It doesn't mean just sitting still. Eye rest means don't read, don't watch TV, don't do anything where your eyes are going to have to move. Because even if you have the eye patched and you're looking at something with the other eye, what's happening to that one that's underneath the patch? Our body's naturally going to try to move it too. So it's very important to tell patients to look at basically nothing, basically do nothing for several days. Nausea, pain are common because you do tend to have an increase in intraocular pressure. They need to report a sudden increase in pain. And once again, avoid those activities that increase intraocular pressure. Glaucoma is a result diseases that result in or cause increased intraocular pressure. Primary open-angle glaucoma is gradual fluid buildup. The fluid can't leave the eye at the same rate it's produced. That fluid that we're talking about is the aqueous humor. So you have that increase in intraocular pressure, which causes a decrease in the blood to the photoreceptors, and that causes ischemia, and those photoreceptors die. Angle closure glaucoma is a sudden onset where the angle, the canal of Schlemm, gets closed and that aqueous humor can't flow out like it's supposed to. You can have a secondary angle closure glaucoma, which can be a result of another procedure like a cataract, have inflammatory process, all of a sudden that canal gets closed, and you have, that would be an example of a secondary angle closure glaucoma. What we need to assess with patient is their visual changes, and we're going to look at some pictures of some visual changes. So let's look at those. Normal vision, then this is early glaucoma. You see it's the outside, the peripheral vision that they lose. Advanced glaucoma, and finally extreme glaucoma, which can lead to complete blindness. Patients have cupping and atrophy of the optic disc. They also had headache or brow pain, blurred vision, and decreased light perception. Tonometry is once again what we talked about, the measure of the interocular pressure. 10 to 21 is normal. Tonography is the graphing of the outflow of the aqueous humor. In gonioscopy, looks at the angle and sees if it's angle open angle or closed angle glaucoma. So here's a picture of a normal optic nerve. Early glaucoma, you can see where the optic cut, and that's from that pressure in the eye pushing back and the damage that's happening to the optic nerve. And finally, advanced glaucoma, because of the pressure pushing back, there's that lack of blood flow, and you see how much thinner it is, the optic nerve and the ophthalmic artery. And those are some real pictures. So what do you do for glaucoma? Drug therapy. Pupillary constrictors, which are the miotics like pilocarpine. You also have aqueous humor blockers, which are beta blockers, and carbonic anhydrase inhibitors. Osmotic drugs, if you have emergency treatment, the main osmotic drug is mannitol, and that is a diuretic that takes fluid from all parts of your body and rapidly diureses. Then you also need to remember you do not want to use epinephrine or atropine in angle closure glaucoma, because that dilates the pupil and that's going to increase that interocular pressure. These drugs are in your pharmacology book on your handout. They're also listed on page 1066 and 1067 in your textbook. The prostaglandin agonist, an example, is Lumigan. If you see that one of the side effects is that it can cause the eye color to darken and the eyelashes to elongate. That sounds a lot like Latisse. That is how Latisse, the medicine that's used to make you have long eyelashes, was developed. People with glaucoma all of a sudden had super good eyelashes, and they're like, oh, that looks good. Let's use that. Adrenergic agonists, which is the Alphagan, and those also reduce aqueous humor. The beta blockers, these beta blockers end in LOL just like all other beta blockers. With all beta blockers, you need to watch out for heart rate, blood pressure. Also, they can mask hypoglycemia in diabetics and can worsen respiratory symptoms in COPD or asthma. The cholinergic agonist, an example is pilocarpine, and those also decrease aqueous humor. And the carbonic anhydrase inhibitors that inhibit the production of aqueous humor, that's Azopt as an example. Okay, so you can look on that chart, like I said, page 1066 and 1067 in your text. Okay, so if we read this, what do we think the answer is? How does glaucoma affect your vision? You want to do a symptom analysis. Do the symptom analysis first, and then we'll get into the other questions. Retinitis pigmentosa. This is an inherited disorder. The first symptom of retinitis pigmentosa is going to be night blindness. They'll also have some problems with peripheral vision and photopsia. Well, they see flashes of light. This is something that the history is going to be very important. It does run in families. It is inherited. So other people in their family will have this. This is rod cone dystrophy, where the rods in the cones, which are photoreceptors, die. The diagnostic test for this is electroretinogram, which measures the rod cone function. Unfortunately, there are no good treatments. They are treated with vitamin A and other antioxidant vitamins. So if a patient is diagnosed with this, unfortunately, their expected outcome will be blindness. So that's the patient we need to really important. It's very important to start teaching ways to deal with loss of vision before they go completely blind. Macular degeneration. that is where the area of central vision deteriorates. You can either have dry macular degeneration, which would be here, and that's a gradual blockage of the retinal capillaries, and that causes death of the rods and the cones. Or wet macular degeneration. That can happen at any age, and it's where the detachment of the epithelium in the macula causes blisters and scarring. And one picture here is macular degeneration. You saw in glaucoma it affects the peripheral vision. Macular degeneration affects the central vision. You can't see what you're looking at. Diagnostic test, they just have a slit lamp exam and assess the vision. Treatments are antioxidants. If it's dry macular degeneration, they want to make sure you avoid smoking. There are some injections that they're trying, although they've had limited success. Laser is a treatment for the wet macular degeneration. However, there are still no really good treatments right now for macular degeneration. The final ocular disease we're going to look at, oh, I take that back, there's two more. Ocular melanoma, almost done, is the most common eye tumor in adults. You can see that. It is a form of melanoma, much more common in light eyes, just like regular melanoma is more common on light skin. You want to, they'll do an ultrasound and an MRI for diagnosis. Treatment is usually enucleation or removal of the eyeball. They also usually have radiation therapy. Important for prevention, primary prevention would be making sure the patients wear sunglasses, especially light-eyed patients when they go outside. The last eye disease is retinoblastoma. That is a tumor in children. The symptom, most common symptom, is a cat's eye reflex. That means instead of having a red reflex, which we know the red reflex is the retina, they can't see the red reflex when you shine a light in there. It shines back white because there is a tumor in front of the retina. So you're seeing a reflection of the tumor rather than the retina. That's the cat's eye reflex. Treatment for that is enucleation. They remove the eye, and usually they have a good prognosis. Okay, that's the end of part 2 of sensory. We focused on the eye. Thank you.